Thank you. Thank you, Julia. I hope everyone can hear me. Okay, so we're going to slightly shift gears from implementation to sort of calibration. So sorry, we have the union logo here because this work was presented at the recently concluded union conference. So my presentation is entitled Calibration of the CAD4TB version 7 system for detection of chest X-ray abnormalities associated with TB in Uganda. So as we heard from previous speakers, the CAD4TB comes with many user options, and one of them is sort of a prescribed threshold score, but also with the liberty to titrate it and calibrate it for specific populations. So that's what we set out to do for the Ugandan population. Uganda is a high TB and HIV burden country. About 30% of all our TB cases are HIV co-infected. We also have quite a number of younger people with TB. And so we wanted to test and see how does the threshold score that is recommended, how does it function in our setting? Next slide. Next slide. Next slide, please. Okay, so we know that the previous slide, sorry. Okay, yeah, so we know that the consideration for the appropriate CAD threshold score depends, one, on the prevalence of TB in your setting and the prevalence of other relevant comorbidities like HIV, diabetes, or even the proportion of patients who have previously had TB. So the number of people coming back with a second or third or fourth episode for TB. It also depends on where CAD will be placed for screening in the screening algorithm. So in Uganda, we have two places for CAD. We have in the community outreaches where we put our digital X-ray and our CAD machines in big vans and they go through the countryside. We want to maximize detection, so we use it as a first screen. So everybody who comes to a community outreach, regardless of TB symptoms, is given a chest X-ray. So that's the first screen. And then if they have a CAD score of 50 or more, then they go on to gene expert testing. But in our health facilities, we use it a little differently. So in our health facilities, we use it to improve the efficiency of the triage system. And this is what is being proposed because we're now revising our algorithm because we know that cough for more than 2 weeks is not a very sensitive is not a very sensitive symptom screen. And so we are looking at sort of reducing the required duration. And we thought that having a CAD as sort of like a second screen would help, improve the efficiency of that triage system. So we don't have to collect so many samples and test them for TB when people don't really have TB. Next slide. So this work was sponsored by the WHO Stop TB Partnership through the TB Reach funding mechanism. And this was wave 8. And so it had a programmatic aim, which was to increase TB case detection through engagement of private providers, and also an implementation research aim, which was to calibrate an ideal threshold score for the diagnosis of TB using the CAD4TB version 7. Next slide. Yeah, so what did we do? So at health facilities, so we chose 2 health facilities where all patients attending the HIV clinic were given a WHO symptom screen. And if they had cough of any duration, they were then given both a chest X-ray and a gene expert test. Then we also had a screening in the OPD where all patients coming into the OPD were given an HIV test, a pregnancy test if they were female, and a WHO symptom screen. If they had cough of any duration, with or without chest pain, evening fevers, night sweats, then they were also given a chest X-ray and a gene expert test. So for HIV patients, if patients were newly diagnosed with HIV, regardless of whether they had symptoms, they also got a chest X-ray. And if patients were returning to HIV care after more than 3 months being lost to follow-up, they also got a chest X-ray and a gene expert test, regardless of whether they had symptoms or not. And then if the gene expert test was positive, the patients were treated for TB. If there was rifampicin resistance, they were referred to the MDR TB treatment unit for second-line therapy. And if they had, if the gene expert test was negative, although they had an abnormal chest X-ray, they were then referred to the physician for further evaluation and management. And if they had a normal chest X-ray and they were MTB negative, then they were sent home. Next slide. So overall, we had over about 6 months of screening, we had 1,344 patients. Of these, 621 were HIV positive and 723 were HIV negative. There were no differences in gender and age and mean BMI between those who were HIV positive or negative. However, there was a difference in age. We find that the HIV positive population was a little older than the HIV negative population. Next slide. Yeah, so about 12% of our patients had previous TB, and a small proportion had concomitant non-communicable diseases like diabetes and hypertension. Tobacco use wasn't very high. It was about 7% in our population. Next slide. Yes, so we calculated the sensitivity and specificity of different CAD4TB sort of threshold scores. And we disaggregated this by HIV positive and HIV negative. So here we see that as a country, we are using a threshold score of 50, which among HIV positive patients, the health facility, not in the community, but at the health facility, had a suboptimal sensitivity. So it had a sensitivity of about 70%, whereas WHO recommends for screening tools a sensitivity of about 90%. So in order to get sensitivity close to the WHO recommendation, we would have, for HIV positive patients at the health facility, we would have to decrease our threshold score to about 15%. Next slide. Next slide. Yes. However, okay, so these are the results for, I think we've missed a slide for HIV negatives. Yes. Yes. So we found that for HIV negatives, the recommended threshold score did not fare very badly. So we had a sensitivity of 85%. And if we lowered it to about 30, then we'd go beyond the 90% sensitivity required for screening tools for WHO. However, we know that there is sort of like a trade-off between threshold score selection and the number of cartridges you're using, because the lower your threshold score, the more cartridges you need to use. So we found that for the HIV positives, lowering the threshold score to to achieve a sensitivity of 90% would increase expert use by about 20%. Whereas for HIV negatives, it would increase the number of expert tests used by about 10%. Next slide. So combining the two populations, HIV negative and positive, in the event that clinicians do not have HIV tests readily available, then we find that the recommended threshold score had a sensitivity of 78%, very close to 80%. But if we wanted to increase that to 90%, then we would have to lower the threshold score to about 20. And this would increase our cartridge use by 20%. Next slide. Yes, so what we learned from this study is that we need more data from the Ugandan setting on optimizing the CAD4TB threshold scores for TB screening in the facility setting, so that we can enable our healthcare workers to detect an optimum number of TB cases while significantly reducing the number of expert tests that are needed. The follow-on benefits to optimizing this CAD threshold score would be reduced results turnaround time, because then the labs would not be so overwhelmed with testing so many patients with expert, and probably reductions in pretreatment loss to follow-up, because we've seen that in our setting, the longer the turnaround time for a gene expert for a sputum test, the higher the probability that that patient will leave the facility, will not come back for their result, and will ultimately have pretreatment loss to follow up. We also know from previous studies carried out in Uganda that patients who experience pretreatment loss to follow up have much higher mortality than those who are successfully started, linked to TB treatment. So if we could optimize the threshold score, then these could be the sort of like tail end long-term benefits to this. However, we have to balance this against the cost of CAD, the cost of X-ray machines, and the cost of personnel to operate these X-rays. So what has happened in Uganda since this study is that we've also had quite a big rollout of digital X-rays and CAD. We now have maybe about 20 digital X-rays with CAD in the country, and some of them have been placed in mobile vans and do community outreaches, and we will have to calibrate a different threshold score for that. But about 15 of them have been placed in regional referral hospitals. And so we are collecting more data, more representative data countrywide, to try and see what is the optimal threshold score for TB screening at the health facility in Uganda. So next slide. Yes, so a very big thank you to Delft Technologies, to the Uganda Ministry of Health, which allowed us to do this study at public health facilities, to the Stop TB Partnership, which provided the money for this study, and to the staff and the patients who carried out this work. Thank you very much.